You're on your own. Everybody assumes it's your fault. And it's also known that you don't earn so much, you have to retire early, and so on. So it's a huge problem. Now, yesterday I talked about BMI 25 as the cutoff point for death. But it's not the cutoff point for becoming sick with the problems of obesity. The proper BMI is probably 20 or 21. I don't know how many people in the audience have a BMI of 20 or 21. But here are women, and before they become even overweight, they have 6 times the risk of diabetes, the risk of heart disease, of blood pressure, and of colon cancer goes up from this sort of level. So it's much bigger. And here, these analyses, as I've shown you yesterday, show that we are no longer in this region dying of malnutrition and of infectious disease. These are the common causes of death, the biggest cause of death, which is why all presidents and prime ministers and emirs and kings have said this has got to be tackled. And the problem here is it's not being tackled. Everybody talks about premature death. These are the deaths from excess, being too fat. But this is the sickness. Look at the difference. 10 times the difference in terms of sickness. We did this for WHO in the first analyses. And this sickness does not come just when you're 80 or 90 years of age. It starts when you're 30, beyond 30s. And that applies for women as well as men. And look at the diabetes. This is global data. This is cardiovascular disease, and so on. So it's an enormous problem. And you are paying a fortune in Kuwait for these diseases when they don't need to be there at all. And if you look at the Middle East and the disability, this is disability adjusted life years. Here's the Middle East. It doesn't look too bad, but these are taking account of the total population. And of course in Asia, Southeast Asia and the Western Pacific, that includes China, this includes India. Middle East, with such a small population, has a huge problem. Now, yesterday we talked about genetics, and we all know that if anybody in your family has got diabetes, you have an increased risk of diabetes that is 5 times greater than normal. And so everybody says that my description yesterday of Asians being, and the Middle East being very sensitive because of previous malnutrition, it's not genetic, as illustrated by this. Here are the Chinese in China, 2 to 3% diabetes, and that the dark blue purple is glucose intolerance. Here at the far end on the right is the Chinese in Singapore who went from China to Singapore 100 years ago. Look at the difference, the highest rate in Asia and almost the lowest rate in Asia, the same genetic stock. So you may be sensitive in your family to genetics, but it's the big environmental factors that are responsible. Now, if you then look at depression and ask about disability from obesity, then in fact you get both actually affect whether you're out of work, whether you're sick, whether you've taken time off work, or whether you're unable to do certain things. And these are the big increases. This is the normal weight. Here's the obese, far more likely. These are the statistically increased risks of being disabled. This is population analysis. It's not just 1 or 2 people, it's the whole population. And if you look at the problems of disability, arthritis, and so on, and you have a big abdominal mass because you're pot belly, then in fact again arthritis is higher, and this is seen in many different countries around the world. I do not know I don't think that's been done here in Kuwait yet. And hypertension is a particular problem. Now, if you then look at the older people, you find that actually very soon they become handicapped, and people get to a point where they can't walk across a room, they need assistance bathing, dressing and so on, and that is particularly true in old age, as well as all these medical complications. And here is the evidence that if you take the high waist compared with the normal waist, each pair you always find far more problems wherever you go in the world. And these are older people aged 80. So as you get older in Kuwait, you can expect a huge problem because you've got 10 times the obesity rates that you had about 30 years ago. So you're hitting trouble at every single level. Now, yesterday I talked about this is a recent problem. Here's the most beautiful illustration of the problem. Obesity only started in children in 1980. This is 100 years of data from Australia, and I've put in Saudi Arabia to show that in this region, that's still on the way up. Japan, India, wherever you go in the world, it's on the increase. And even the children are in trouble. All these slides are available to you, so don't worry, you don't have to photograph them. And if you look at the increase in weight, this is the increase in risk of carotid thickness. In other words, you can predict the increased atherosclerosis already in a young child. And if you then ask, well, if you've got a beautiful Kuwaiti boy and girl who you think are fine because they look so healthy, actually their weights are probably 1 standard deviation above the normal. That means that they've got an increased risk of dying early, and they are more likely to die of cardiovascular disease. And that applies here. This is beautiful data of people, babies measured from birth to death. So this is the most incredible data for boys and girls. And if you keep children plump, not fat or obese, just a little overweight, the risk goes up and up as you go through adolescence. So we really have to do something pretty drastic. Now you say, well, okay, let's put all this evidence together. And here is the WHO analysis that's 10 years old. And here the question is, how do you decrease risk? You've got to, of course, be physically active. You've got a high fiber diet. And then we show that the home environment is bad. And the increased risk comes from energy-dense foods, as I described yesterday, and heavy marketing of foods. The marketing here is incredible. And sugar-sweetened soft drinks and fruit juices, this is up in the policy area. We told the world about this, and it went to every Minister of Health. We personally made sure it went to every Minister of Health 10 years ago. Now, just to make the point, here is a new European study that's just been published, showing that if you take dietary energy, including soft drinks, and look at the incidence of diabetes, there is an increased risk specifically of diabetes, and it's not actually related, in this case, to obesity. So there's a suggestion that obesity, we know that obesity causes diabetes, but if you're on a high sugar intake, it looks as though you may be getting even more diabetes. And a lot of people think that it's not yet policy, but the evidence is beginning to come. What we do know is if you ask people how to lose weight and keep their weight off, then the people who maintain the weight loss, they have a lower concentration of energy in their food than people who in fact are overweight and have a much higher, 0.77101. And in fact, all the evidence is if you're going to maintain people, you have to change the whole food system in the home to get rid of this disability. Otherwise, they'll just go back up to the same weight. Now, there's a big lot of publicity coming out of the States suggesting that actually, you know, it's very difficult to keep people down in weight. Here are older people who are quite sick. They have diabetes and heart disease, and we studied them in 16 countries across the world for 6 years. You can actually bring people's weight down. We actually, in one branch, had sibutramine, but that's not the point. Even placebo, you can keep their weight down if you follow them and give them incentives as you go. And if you do that, here's somebody with severe cardiovascular disease. Let's get them to lose weight. And the more weight they lose, the less heart disease, cardiac disease, and death that they have. So this is the first evidence that even in people with diabetes and cardiovascular disease, you can get this. Only in heart failure do we have a problem with weight loss. So if you actually look at the cost effectiveness in a clinic of how to treat everybody, if you tell everybody lose weight, and of course and don't give them any special advice, then it's very expensive. These are in euros. That's too expensive for most health systems. If, however, you actually get the patient involved themselves, the expense is halved. If you have somebody who is sick, for example, with diabetes, and you get them to lose weight, it becomes much more cost effective. In other words, do not give up on people who already have heart disease or diabetes. And if they have the whole gamut, they've got diabetes, hypertension, dyslipidemia, this cost is more cost effective than almost any other treatment system in medicine. So it's completely crazy that we are failing to manage obesity properly in the clinics. I've talked about diabetes prevention. This is the evidence in a country. These are the reductions going on, the reductions in obesity that you can have in the whole population if you screen people and intervene with dietary policies. Now, it's not just a question of getting people slim. If you put people on a higher fruit and vegetable diet, their blood pressure comes down. If you drop their fat intake as well, their blood pressure drops even more. In other words, the way you treat the food system is important. If you reduce their salt, down comes the blood pressure. And it comes down not only in the hypertensives, but also in people with normal blood pressure. Please note, there is no such thing as a separate group of genetically sensitive hypertensives who are only responding to salt. Everybody responds to salt, but some people respond only a very little, and some people respond hugely. And that's only in part genetic. Can you make a difference finally? Yes, if you reduce in a Chinese factory the salt and fat that you put in the food that they eat in the canteens, and tell them not to add so much salt at home, you drop their stroke death rates by 75% within 5 years. That's the most incredible data. This is not just what you think is going to happen. These are actual numbers that we managed to force them to publish because it's changed the whole public health of these factories. So you can work in the workplace as well as in the home. And in terms of cholesterol, people are now saying, is cholesterol important? Here is the increasing death rate from heart disease. In any country you study, you have to be in Japan where you've got incredibly low heart disease and actually plenty of fish and so on, and very little saturated fat but even so, in practically every other country in the world, as your cholesterol goes up, up goes your death rate. And it relates to the saturated fat in the diet. So in conclusion, we've got a massive epidemic. Nothing's being done about it nationally. in any country in the Middle East so far. It's been a huge problem that's getting worse by the generations. In Europe, we're starting to tax and regulate, as I talked yesterday. But medical care, you have to have long-term monitoring. We may get new drugs, but it's time a national program for prevention to cope with the disability of diabetes is instituted. Modest weight loss does work, but you have to look at the diet as a whole. Diabetes can be prevented, and it's not good enough to say that it's difficult. Thank you very much.
Thank you, Professor James. Now we'll present Dr. Iman Al-Busiri. She will present us a lecture on complication of childhood obesity. She is graduate from Faculty of Medicine in Kuwait University. Then she had her pediatric training and fellowship in Our Lady's Hospital for Sick Children in Hospital in Dublin. She's a pediatric endocrinologist in Mubarak Al-Kabir Hospital in Kuwait since 2008, and her main interest is obesity, growth, and vitamin D, and health and care quality. Currently, she is involved in 3 years research on cellular and molecular basis underlying childhood obesity in Kuwait. Hope you will enjoy the lecture of Dr. Iman.
So today I'm going to speak shortly about the endocrine causes or what we see exactly in our clinic, and then I'll go through the metabolic or complication of obesity in children. As you know, that obesity is a global rise in all the world, and it's not in adult but also in children, and we're seeing a lot of obesity even under 5, which with premature death. In Kuwait, So in Kuwait, the prevalence of obesity, which is a study done, is around 26.5%, and it's higher in boys, and then you see the trends is increase over the years. So, as you know, obesity is commonly due to simple obesity because of the overeating, but we do rarely see endocrine causes, which I think I just want to highlight them and give them or what exactly really we come in our clinic. So, endocrine causes, commonly we see hypothyroidism, and rarely we see Cushing's syndrome, which I'll mention later about each. Other rare causes is genetic syndrome. The commonest is Prader-Willi syndrome. So hypothyroidism is very common, and it should be checked in each child with obesity, especially if they are short and with other symptoms. We do see a lot of subclinical asymptomatic, so it's worth checking, and there'll be dramatic weight reduction when you give them the medication, completely change their features. Cushing syndrome is quite rare disease. It's 1 in a million. They characterize this buffalo hump and central obesity, but if you see practically of our observation, all, I think, morbid obesity, they behave or they have the similar characteristics. So you end up doing all cortisol level. So you have to be careful with your, how much tests you do to these patients. But generally we do 24 hours urine cortisol, which is very sensitive, and also cortisol BM. It gives you an idea if they are, and if still suspected, we go to dexamethasone suppression test. Treatment, it's mostly surgery, but if you treat them, still their BMI will not go dramatically as the hypothyroidism. They'll still be obese. Growth hormone deficiency, it's a common disease we come across, but mostly they come because of short stature, but they have association of obesity with that, and especially truncal obesity. And if you treat them with growth hormone, there'll be reduction by 2.5 of the body mass, because they improve the lean mass, and but they have a significant risk of metabolic syndrome. Other rare cause, which is the genetic syndrome, the commonly Prader-Willi syndrome, and it is 1 in 16,000. As you know, there is a genetic due to deletion of the chromosome 15. They presented with neonatal hypotonia and early poor feeding, and they will become obese as early as a young age, and with short stature. And they have a great problem with obesity, and it's quite difficult to control their obesity. Other rare causes, it's pseudo-hypoparathyroidism, which is autosomal dominant, and also they presented with obesity and treatment with hypercalcemia, but that will not improve their BMI with this treatment. Genetic, I think yesterday Dr. Sari gave us a beautiful speech about genetics, and I'll not speak much about them, but I just want to highlight this genetic as a cause. I don't think as a clinician is quite important, because it will not affect much of your treatment, but I think one should know that there is thousands of genes related with obesity, and the commonest is FTO. But just to mention, there is a leptin deficiency, and I just want to highlight it, even it's very rare. And I used to do leptin for all children less than 5. Now I'm not doing it much because it's a very expensive test, and we hardly ever see any positive result. But the importance on this patient, if you treat them with subcutaneous injection, there will be dramatic improvement so it's worth thinking about it and do these tests if you suspect it. So that's mostly what is the cases we come across in our endocrine clinic. But if we move to complication of obesity, I'll just highlight a little bit on, and I didn't mention other risk factor because I think of the time, but if we'll talk about metabolic syndrome in children, as you know that obesity can lead metabolic syndrome, and metabolic syndrome is basically hyperinsulin or insulin resistance syndrome. And it is basically a cluster of risk factor, which is the central obesity, hyperlipidemia, altered glucose metabolism, and hypertension. And these all risk factors which can lead to cardiovascular disease and type 2 diabetes. And the incidence is highly, not in an adult, but also we're seeing a lot of complication in children even under 5 years of age. So how you define metabolic syndrome? It's quite difficult to define it, and there is hundreds of literature that will tell you about the discrepancy of the definition of a metabolic syndrome, and that of course will affect our prevalence rate. And IDF recently come up with a set of criteria which can help us to define metabolic syndrome, and then we will have standardization of definition, and then we will all speak about same language if you're talking about the prevalence rate. So sorry for this messy slide, but just to highlight what is the criteria or what is the points need to know in metabolic syndrome. So you have to be obese, you have to have high triglyceride, low HDL, and high blood pressure more 130, and with altered blood glucose 5.6, or any suggested of type 2 diabetes. So as I mentioned, the prevalence is quite high, and the mean overall prevalence is 3.3, but that varies from different centers, which is range up to 19.2. They found the prevalence of metabolic is much higher in boys than girls. And if you subdivide them according to the component, you'll find 24% of participants, they have one risk factor, while 8% they have two, and 0.3% they will have all the 4 components. And if you see, insulin resistance is consistent of 65% of adolescents in metabolic rate, which surprised me. If you look on the criteria of IDF, they didn't include the insulin level, which I think high insulin level is quite important to be added in the criteria, because we will get much higher prevalence, because we'd see a lot of hyperinsulinism. Also, the prevalence will be varies according to the ethnic group, and it's much higher in, I don't think this is clear, it's much higher here on the African American and Hispanic, and also in Asian American. If you see our study in Kuwait, there was a study done a few years back looking in the metabolic syndrome, and the incidence is quite high of 27.8. Sorry, it's a prevalence, 27.8, and 26% they have one criteria, and 35 has two sign of MS, which is quite high among Kuwaiti population. So if you're looking what is the underlying or what is the pathophysiology of metabolic syndrome, you can see that the main issue, as I said, is insulin resistance. So with the adipose tissue, they will stimulate the insulin resistant, they will have high insulin level, and then will be altered glucose metabolism. Also, there will be high, I don't know if that will be clear, there will be increase of the free fatty acids here, there will be increase of the free fatty acid and the triglyceride. These also they will deposit in other cells other than the fat. They will be deposited in the liver, in the skeletal, pancreas, and also CNS. And with the liver, then they will have liver cirrhosis and hepatitis. With the pancreas, they will affect the pancreas cells, and they will therefore will have insulin deficiency and type 2 diabetes. There is a lot of metabolic causes or pathway. There's endocrine, inflammatory markers, which can modulate this process. So it's not a clear pathophysiology what is the cause, but everybody blame hyperinsulinism for that. So what is your risk factor? I think yesterday we had a beautiful lecture about how the effect of intrauterine, fetal, and the weight at intrauterine and postnatal on the risk of obesity. So I will not speak much about that, which is illustrated beautifully yesterday. So, as I said, metabolic syndrome, also there will be, if you have one of these criteria, there will be risk of type 2 diabetes, and basically it's the endpoint of hyperinsulinism. And it's incidence-wise is around 1/3 of a new diabetic in some center, and it's considered in 92% of them